It's hard to say in that viewer's instant what the success rate should be. But for paroxysmal atrial fibrillation, most studies say it's about 75%. For persistent, you're looking more at 60%. There was a recent study that was published looking at paroxysmal atrial fibrillation, which actually showed a 62% success rate. So,
let me interrupt you, Doctor. Yeah. Tell me what you're doing right here.
Yes. Yeah. So this is the ablation catheter. This is actually the catheter that we use that delivers radiofrequency energy.
Was that water? Just water?
And it was saline. Uh-huh. And what that does is, as you might imagine, we're converting electrical energy into heat.
Right.
And so that catheter is heating up a lot of tissue inside of the heart, which is our purpose. But what we want to do is focus that energy in one particular spot. So what we do is we have a saline irrigated catheter which cools all the tissue surrounding the ablation catheter and allows us to deliver a pinpoint ablation lesion, which is a lot deeper lesion than we would normally see. Again, not everyone historically has used what we call irrigated tip catheters, but the move is definitely across the country that these catheters are definitely more effective than traditional catheters. So I would say it's almost becoming the standard of care to use irrigated tip catheters.
Safety issue, you would agree too. There's less risk of thromboembolic or char forming on the catheter, which can cause strokes. So that's another issue.
Speaking of complications, we have a question, or potential complications, I should say. We have a question from someone saying, I understand that there is a potential complication that can involve the esophagus. What is it, and what do you do to minimize this risk?
Sure. And actually, later on in the talk, I have some slides to actually particularly address this issue. But what I can say for now is what we do is we use an esophageal temperature probe, which is a temperature probe that's passed through the esophagus, and we monitor esophageal temperature. So if we see any heating of the esophagus, we generally move our ablation away from that point. If we are on top of the esophagus, we turn down the power on our ablation. We don't use as much power. So we do several things in order not to injure the esophagus. But I'll address that specific point a little bit later.
Great. And we do have some slides, and we'd like to go ahead and take those slides now, and you can tell us a little bit about what we're looking at with that. One of the things I wanted to ask you, too, someone writes, when my AFib kicks in, it runs at 250 beats per minute. How long can I stay in this state and still be safe?
Well, 250 beats a minute, that's fast, and the likelihood is you're going to feel really poorly and may even pass out depending on age and what your heart function is.
Sure.
So certainly if it's 250, you should seek medical attention pretty quickly.
Okay, most definitely. It sounds like a lot of these folks with a variety of questions should pose these questions to their own physicians.
Absolutely.
It may not be AFib, but it might be something.
It could be something else. It's
Absolutely.
Not always atrial fibrillation when you feel palpitations or rapid heart rate.
Sure. All right, can we take a look at those slides and let Dr. Cervello tell us a little bit about what we're looking at?
Sure. This first slide we're looking at is actually an image of the circular mapping catheter inside of the right inferior pulmonary vein. So you can see this catheter has 10 electrodes, and each one of these electrodes actually monitors the electrical potentials that are emitted from both the left atrium as well as the pulmonary vein. And what you can see next to it is the ablation catheter, and that catheter is then positioned in front of the lasso catheter and then moved around in a circumferential fashion to isolate that vein from the rest of the heart.
That's fascinating. I'm sure this is a good educational tool to talk to patients ahead of time and say, now, this is what we're going to do.
Sure. A lot of these things are when you talk about ablations, sometimes it's hard for a patient to actually understand what we're speaking of. So using visual tools definitely does help.
Tell us about this.
This is actually what I spoke of when we use the CT scan. We use it to show exactly what the pulmonary veins look like. And in this view is as if you're sitting inside of the left atrium and you're looking down each one of the pulmonary veins. So on top is the right superior pulmonary vein.
The blue circle.
The blue circle.
Okay.
In the middle is the right middle pulmonary vein, and on the bottom is the right inferior pulmonary vein. Initially, when we first started to do these ablations, we ablated in the blue area, in the blue dots you see there. And what we found was that by ablating so far inside of the vein, we actually caused something called pulmonary vein stenosis, which meant that the vein would get smaller from so much scar tissue. So the method that we use now is we do more of a pulmonary vein antral isolation, meaning we pull back and we ablate more inside of the left atrium than actually close to the pulmonary vein. And we do that to prevent complications.
And it's just as effective?
It's just as effective, probably more effective, actually.
Okay. Wow. What is the recovery period like after this procedure? Your patient, 1 month out? Back to full
really,
activity?
the next day they're up walking around and back to their normal activities. We ask them not to drive for a few days, but really, and no heavy lifting or heavy activities for a few days, but really they're back to normal. They're going to feel some palpitations, some of the patients, but really in a month they should be very much back to normal if it's a successful case.
What about exercise routines, other lifestyle changes, dietary changes? I mean, are these all part of the package?
All hand in hand, yeah. They should definitely follow the heart healthy lifestyle, reduce sodium intake, watch their fat intake. Alcohol certainly plays a role in atrial fibrillation, so I tell people to abstain from alcohol, reduce caffeine intake. So really, exercise and weight loss they all go together.
For all of us.
That's right. Yeah, I think it's important to remember that we're trying to cure the atrial fibrillation that the person is having now. But, potentially if your blood pressure continues to be high, you continue to gain weight, you're going to set up problems in the future, which certainly may predispose you to have more arrhythmias in the future.
Sure. Let's continue with looking at our video of the surgery and let you guys tell us a little bit about what we're looking at as we continue to get lots of questions, and we thank you for sending us your emailed questions. All right, where are we right now, Doctor?
Yeah, so you can see there, as you mentioned before, there's a lot of information that we're looking at here. We have, 6 different screens that we're looking at, and we use each one of these screens in order to tell us where we're located. We use fluoroscopy, which you can see the fluoroscopy is the tube that's actually moving right now, and what that is basically an X-ray machine, which is taking pictures of the patient's heart in real time. Also, you can see here the team that's involved. This is not certainly a one doctor thing. We have a lot of support staff, as Dr. Smith mentioned. We usually have 2 nurses and someone else who helps with us, as well as someone helping with the mapping.
How much setup time is involved before you bring the patient into the operating room or into the cath lab, or the specific lab for this? It seems like there might be a good deal of
takes a while.
Technological work involved.
Usually we try to start around 7 o'clock in the morning, and so the patient usually arrives around 5:30. They get IVs, make sure their laboratory work's in order, make sure all their medications are in order, and then once they're brought back into the room where we perform the procedure, they have to have their the areas where we're gaining access to the body prepped and made sure they're sterile for the procedure, and then catheters placed for the nares and for the esophageal probe, for the temperature probe. So it takes around 30 to 45 minutes to actually get them ready for the surgery, and then the surgery is another 4 hours or so.
It's kind of lengthy, but it's amazing to watch and see everything that's involved with it.
If you can imagine when this surgery was first started, it was taking probably 12 hours to do.
My goodness.
So
what an improvement.
Yeah, so to get down to 4 hours, and in some cases it's even less than that, it's all really credited to a lot of people out there really helping with the technology to make this a safer and more effective procedure.
Tell us what we're looking at here. Lots of color. Is this, again, the merging of the different images together?
Yeah, so what you're looking at here is actually, we've highlighted each of the 4 different pulmonary veins, the right superior pulmonary veins in blue, the right inferior pulmonary veins in purple, the left superior pulmonary veins in purple on the left-hand side of the image, and in green is the left inferior pulmonary vein. And what we've done on the image on the right side of the screen is actually cut away the heart, and we're looking as if we're looking down into the left superior pulmonary vein as well as the left inferior pulmonary vein.
Is that actual size, what you're looking at?
Yeah,
when you're in the, okay.
Yeah, it's actual size. And again, this is just another modality, but by looking at this echo image, I'm able to tell that my circular mapping catheter is right outside of the pulmonary vein.
And how long does the actual